In this next section of the presentation, we're going to look at cognitive errors and cognitive biases. As humans and healthcare practitioners, we're all prone to cognitive biases that can result in cognitive errors. In this presentation, we're going to take a look at the impact of cognitive errors, the origins of our biases in relation to System 1 and System 2, and how we can divide cognitive biases up into how they affect us. As the interest around clinical reasoning grows, so does the interest around cognitive errors and how they impact patients' experience, morbidity, and mortality. Cognitive errors actually account for the most errors made within clinical practice. A recent study by Singh and colleagues in 2013 examined 1,000 case notes, and what they found was that 13% only related to the interpretation of diagnostic tests and errors associated with them, but nearly 80% actually related to cognitive errors made by clinicians in the diagnosis and management of patients. Most of these errors actually related to the clinical reasoning and the pitfalls of cognitive errors and biases rather than the knowledge of the patients. So this shows that although some clinicians may lack knowledge in an area, if they're aware of biases, they're able to mitigate against these and therefore mitigate against errors. So what are cognitive biases? Sullivan and Schofield provide a really good definition about this. And I think the key aspects about this is that highlighted in red. These are subconscious deviations in judgment, leading to distortion, inaccurate judgment, and illogical interpretation of reality. And this is a key point about it being subconscious, that these are normally associated with your subconscious reasoning system, System 1. And this is where the biases inherently are found, but also can be counteracted using other measures. We can actually divide these biases into 4 categories. The first one is social, in that we have biases against people's social standing, where they may live, their postcode, how they look. And when we see a patient, subconsciously we're always biased about how they look and how they present, because that's part of our clinical examination. But this can have profound effects on our ability to treat them and our willingness to treat and manage them as well. We have biases in memory as well, in that some cases are more easy to remember and some cases more difficult. And this is a bias in itself called ascertainment bias, which we'll explore later. We also have biases in decision making, in our preferred way to make decisions. Some people argue that they're more intuitive and they like to make intuitive decisions, but this is biased in itself, that we then don't move to the more analytical method of thinking and we're more prone to bias. Finally, we have biases within the probability and our own beliefs as well. We have biases in how many times we think that an infection can be a chest infection, a urine infection, an intra-abdominal infection, and we have biases about our beliefs of the probability of a disease process being prevalent in a certain population. There's actually over 100 biases that are documented and known about, but later in this presentation I've picked 18 that I think are more clinically relevant to most of us. So where do these biases originate? And we can relate this to type 1 processing and type 2 processing, dual processing. Although this diagram looks a little bit complicated, let's break it down a little bit. First of all, we have our patient presentation, and then we have our pattern processor. We can liken this to script theory, where we're able to see patterns in patients' presentations, and if that is the case, generally it goes to recognized and type 1 processing begins. However, if our script theory is not complete, perhaps because of inexperience or an unusual presentation, it would move down to the not recognized, where we have to use type 2 processing and use more analytical means to get to the bottom of the problem. We can see that the memory that we talked about plays a key part here as well, in that repetition and pattern recognition allows us to move to a type 1 process. The important thing about this diagram is that biases generally derive from type 1 processes, which we'll explore a little bit later. The important part as well is that type 2 processes are able to override these, and this is denoted by the executive override, where what we're able to do is that if we actively move into a type 2 thinking about thinking, or thinking if we're wrong or could potentially be wrong, and employing some critical analysis, we're able to override the biases that type 1 often presents with us. The T represents that we're able to toggle between both type 1 and type 2 processes, as this is dual processing. And another advantage as well is that we're able to avoid being unrational, dysrationalia, by moving into a type 2 process in order to solve the problem. Here we can see that ultimately each aspect ends up in calibration of the problem and a diagnosis. The key point is that type 2 processes are less likely to be influenced by bias than type 1 processes, because within type 2 processes we're able to actually identify the bias and take active steps to counteract this. As we've identified previously, type 1 processes are generally more prone to bias, and we can split these up into 4 categories. Some of those are hardwired by natural selection, and those are innate with us that we can't change, and these are heuristics and shortcuts. These can be some things like anchoring, where we're more likely to think about the first thing that somebody says, representativeness, in that we're able to only represent things that we have experience of, and availability biases, in that we're only able to draw to mind what we can remember. Within these, we might be more prone to satisfying and overconfidence, and these biases are defined in the next section of this presentation. The second part is that emotions can also bias us, and these can be split into categories of happiness, sadness, fear, surprise, anger, or disgust. These biases may be also learned or acquired. We can also be biased by overlearned processes, and we can liken this to the frequent presenters that we sometimes see in primary and secondary care. And sometimes when we see these patients, we can be biased into thinking that we already know what the problem is, or essentially sometimes we can be tempted to inaction or action, depending on their presentation. So experiencing something repeatedly can bias us towards it having a certain conclusion. We can also learn bias implicitly through learned processes. And typically this is part of experiential learning, but sometimes when we're with a mentor or other staff members and colleagues, it's likely that we may learn from them and learn their biases as well. The biases may never actually be deliberately articulated to us, but we might have acquisition biases towards age, economic status, gender, race, or patients with a psychiatric problem or mental health issues, as well as obesity. And this is sometimes learned through our interaction and experience with colleagues, mentors, and teachers. As we can see from this section, biases are inherently ingrained into System 1 thinking, and sometimes these are either innate or learned from experience, and it's the job of System 2 to try and discover these biases, counteract them using various techniques that we're going to discuss in the next section, and then ultimately avoid us making an error.